I'd like to thank Initial for asking me to be part of this webinar on updates in ophthalmology. All three of the authors declare an interest in the laser that will be discussed here. In all cataract surgery, the perfect capsulotomy should be of the correct size to get 360-degree IOL coverage, of the correct shape, circular, to get symmetrical capsular contraction, in the correct place to place the IOL optic on the visual axis, and with a strong elastic edge to avoid tearing during surgical maneuvers. Is there a technology used in adult eyes which might help in achieving this in pediatric eyes? There is selective laser capsulotomy using a laser. SLC requires the anterior capsule to be stained with a microfiltered solution of trypan blue 0.4%. This acts as a target for the laser beam to be absorbed and thus create, using a low temperature continuous thermal beam, a circular capsulotomy. The laser has converted the type 4 collagen of the capsule into the amorphous collagen at the capsulotomy edge. And this edge is highly elastic, and studies have shown it is stronger than both manual CCC and femtolaser capsulotomy. SLC is carried out with capsulaser, which you can see mounted on a microscope on the left. There's a console which fits onto a tray beside the microscope, and this sets the size of the capsulotomy between 4.5 and 5.5 millimeters, and there's a foot switch to make it all happen. Now let's prepare the eye for the laser. First thing we're going to do is inject the microfiltered trypan blue. This has a greater specific gravity than aqueous, which means it sinks to the bottom onto the surface of the capsule. It's normally left there for about 30 seconds and then is thoroughly washed out using BSS. Once this has been done, you can see this going on now, we will inject some 2% sodium hyaluronate. This is to fully fill the chamber. It's important to make sure that the anterior chamber is over deepened and the surface of the capsule is as flat as possible. And you can tell this by getting some extra OVD coming out of the wound. Now turn on the laser, and once we've done that, we can start to center the beam. And once the beam is centered, then the foot pedal will be depressed, and in less than a third of a second the capsulotomy will be created. We're ready to fire now, and there we've got our capsulotomy. Interesting with this white cataract, there's no movement forward of any of the soft lens matter. The surface doesn't get disturbed until you actually take out the capsulotomy cap underneath the OVD. The lens has now been implanted after the cataract been removed, and you'll see that there's good 360-degree coverage. Capsulotomy centration is not obvious because there are a number of different axes. There's the pupillary axis, center of the pupil. There's the optical axis, which goes through the center of the eye. And then there is the visual axis, which ends up on the fovea. Deviations from this will be either angle kappa or angle alpha. So how are we going to consider capsulotomy centration? Because it's a non-trivial issue due to the asymmetric 3D optical nature of the eyes I've just discussed. There's also the possibility of intraoperative patient tilt, asymmetric mydriasis, and resultant resting location of the IOL. This is further exacerbated in hyperopic eyes, as we know, because these patients have a large angle kappa. The mesopic pupil will center not on the visual axis, because there may be displacement. This can be nasally as much as 0.3 millimeters, inferiorly 0.1 millimeters, or the worst case scenario is 0.6 millimeters. In a hyperopic eye, this can make quite a difference. The important thing to remember is that the IOL, if it's biaspheric, has relatively little tolerance of decentration of the IOL from the visual axis. Here's an example of pupil centration, which is obviously not on the visual axis, because you can see the Purkinje images here. So if it's not the limbus or the pupil which are the landmarks, which one will yield better centration? As noted on a previous slide, there appears to be enhanced staining in the center of the capsule, which we call the trypan blue capsular landmark, and it is coaxial with the Purkinje image. The coaxial Purkinje image is well accepted for corneal refractive surgeries of the visual axis, but is this also true for IOL centration? An intense trypan blue stain, centrally located on the anterior capsule, is present in over 95% of eyes, and it tends to be of a size approximately 2 to 4 millimeters. This feature had been found but not discussed in previous studies using the femtosecond laser with stained capsular caps. A recent study has been undertaken to look at the importance of this landmark in relation to capsulotomy centration and the Purkinje image. There were 117 eyes in the study. The first 28 were used for induced pupil centration. The other 89, the centration was done using the capsular landmark. 95% of these eyes, in fact, had a good landmark present, and this was coincident with the third Purkinje image, with a displacement of less than 0.1 millimeters. And likewise, the coaxial Purkinje image and IOL centration were also coincident with 0.1 millimeters. The mydriatic pupil-centered capsulotomies were notably decentered from the IOLs by 0.3 millimeters. This compared with the group 2, the ITC-centered capsulotomies, where the displacement was 0.15 millimeters. And this was significant at a value of 0.05. So the benefit of the landmark being located on the anterior capsule includes sensitivity to tilt and also confirms patient fixation, serving as an alternative to the Purkinje image. Here we can see some examples of the correlation between the TBCL and the coaxial Purkinje images. In other words, the visual axis. If we look at the control arm, in other words, centered on the pupil, we can see that there is a range of decentration up to 0.5 millimeters. The Purkinje image and IOL position with TBCL centration shows a very different picture, with very good correlation between these two ways of looking at centration. Here are some further thoughts about the study. Not only was capsulotomy centration on the Purkinje image and TBCL superior to pupil centration, but we also made some interesting observations. Is that the resultant IOL position appears centered on the visual axis, which implies the capsulotomy bag is centered on the visual, not the optical axis. And therefore the TBC landmark is associated with the anatomy of the capsular bag, hence both are centered on the visual axis. So how will SLC work for a pediatric cataract? With the patient under general anesthetic, there will be no further movements required as there might be if you're using a femtosecond laser. The steps of the technique fit into the normal surgical routine. The capsulotomy size can be chosen and created accurately. It will be circular with a strong edge, and by using the trypan blue capsular landmark, accurate centration can be achieved with ease. And this will mean IOL placement on the visual axis. Thank you very much for your attention.